Welcome everyone. Today from IIP Paschim Medinipur branch, we welcome you everyone for this webinar. Topic: exercise prescription, the ultimate food for good musculoskeletal health. It's a very beautiful topic, especially the exercise prescription, the way how you are supposed to do an exercise, how you are supposed to prescribe an exercise to a patient for improvement of their musculoskeletal health. That knowledge is very important. Otherwise, we will end up in a jumbled up regime and we will not get the fruitful result we are supposed to get, right? So I welcome Dr. Sanjay Sarkar, our speaker for this webinar, and let's talk something about him. He is the first MPT degree holder from West Bengal. He started MPT course at NIH, BPT courses at Nopani and Ramakrishna Mission. He then went to USA to complete MS and PhD through United States government scholarship. He was taught osteopathy by none other than the father of modern osteopathy, the late Dr. Philip Creeman. He was an assistant professor at Concordia University and visiting professor at Minnesota State University. He was also research scientist for Mayo Clinic, the world's best hospital for the past 18 years. Director at Minnesota Gerontological Society, member of American Physical Therapy Association, member of American Society of Biomechanics, president and founder, Institute of Movement Science and Research, department head and Remove Pain Clinic, visiting professor at Minnesota State University. You have a very long list of acknowledgements, and I hope today's program will be also a very nice program. Today, this is the first webinar organized by the Paschim Medinipur branch, and myself, Dr. Anvesh Pradhan, is welcome you everyone to attend this webinar, and we can go through, I think, Dr. Sarkar.
Perfect. Yes, let's get started. Good evening.
Then. Okay.
Okay. All right. So good evening, everyone. Thanks for joining in. Whoever is live in Zoom or through Facebook, please do remember to subscribe to IIP Central channel for getting updated feedback and some knowledge-based information for to help improve your practice, clinical practice. I would essentially thank Dr. Pradhan for saying such wonderful words about me. I didn't even know that I had so many, kudos on my shoulder. Probably I'm old. That's the reason I have a little bit of a longer list. Thank you, whoever is the EC members, CC members, and whoever, our president and our treasurer and everyone. I thank them to help me, get this podium for you to share a little bit of insight about exercise physiology and exercise science. I would like to thank also Dr. Nimai Dash. He is a stalwart in West Bengal in terms of physiotherapy practice, and he is a pioneer in Medinipur district in terms of education and academia of physiotherapy. Probably he's having a tough time getting in the connection, but I do thank from the bottom of my heart for the entire IIP Paschim Medinipur branch for hosting this event. So without further ado, I would share my screen. And so the talk for today is extremely basic. Usually that's what I told, I get a lot of information that I talk about a lot of higher, knowledge-based and information-based stuff. So today I thought, okay, let me whittle it down to very basic kindergarten, KG, and 1 and 2, or probably Montessori stage of BPT. So today's talk is completely geared towards first year, second year, and probably a little bit towards the third years also. So again, let me share the screen with you. Bear with me for a second. I hope you'll be able to see in a jiffy. And there you go. All right, I am pretty much sure you can see it. If you don't, please let us know on the comment section. Let me go into a widescreen mode and use a slideshow. Okie doke. All right, I think we are good. All right, so today, let me minimize this. So one sec. Anyone, can you actually get my picture over here? I'm not sure how to do that. There is a way, I know you can do that in Zoom where I can see my picture, but I'm not sure if you can do that from your end. Whoever is in the IIP technical team.
Sir, your picture is visible.
It is. All
Yeah,
right, now actually I
yeah,
have to pin my video. I forgot that thing. All right,
yeah.
thank you. All right, so exercise prescription strategies for optimizing musculoskeletal health. Now, from the very outset, we all are PTs, physiotherapy or physical therapy. Everything starts with something that is physical. But in a certain, aspect, you see, whenever you see a patient, you jump into, or we jump into give some modalities like TENS, IFT, shortwave, ultrasound, this and that. We tend to forget exercise, which is supposedly our bread and butter. In fact, the premise that I believe in is, if you want to be a successful PT, a successful healthcare professional, as somebody who is different than other physios, and especially someone who is different than, like, so-called quacks or physical therapy or physiotherapy technician, you should know how to prescribe exercises. And in my past about 16 or 17 years teaching mostly abroad in US, I have been an anatomist, meaning I teach anatomy, thereby I had to dissect cadavers on my own. So for me, exercise like is a visual thing for me as well as my patient, to make them understand that this is the ailment, then this is the correct exercise that he or she needs to be doing. Now, how would you prescribe an exercise? People always tell me, like, I have been doing workshops for God knows how many years now, probably over a decade. And my students and my proteges usually tell me to, okay, give me a name of the exercise. Well, to my understanding, it's not an exercise that you do in a fitness gym based thing with iron, like pumping irons and make bodies like, Bollywood, movie actors and stuff. This is not the exercise that we are dealing with. So a patient, if this is a normal threshold, when a client comes to you, he or she is subnormal. And the exercise that you give him or her will pull him or her to normal level. The exercise that is given by gym trainers are for fitness level, which is beyond normal capacity, right? Beyond normal capacity. So you have to think in that way that, oh, I'm not going to give like a bicep curl or, a leg extension or a leg press. That's not the exercise we are talking about. So what are the types of exercises, on what is the thought process of giving an exercise, prescribing exercise when you are talking about, again, musculoskeletal? I am a complete newbie in terms of neuro. Probably I can't even spell a neurology right now. It's been so many years that I have left neurology. I am right now more into biomechanics and osteopathic chiropractic type of thing. So my brain is etched in understanding the muscle action, angle of pull, and line of action, how many joints that muscle is crossing, meaning the levers, first order lever or second class lever, or what are the types of muscles that are activating or inhibiting that motion. Those are the key things that I have to think about before I jump in prescribing exercises. So today we are going to understand and interpret foundational knowledge in a clinical setting, and then hopefully we will go talk about a little bit of strategies, a little bit of guidelines, understand the different key principles if it's possible, and then describe obviously the very basics, bread and butter. What are the benefits and functions of an exercise, right? And obviously understand a little bit of how nutrition, diet and nutrition, can help improve exercise ability for your client who has issues in completing the regimen of exercises that you are prescribing. Again, just probably or at least you will know at some point in your career that exercise prescription is a course by itself. In US, there is a Master of Science in Exercise Physiology. So you understand it's a 2-year course that I have to, sandwich it in 1 hour or less than an hour. So bear me some, appreciation in terms of I will not be able to go deep into all the exercises and the nuances of it, but just, it's all I will be touching or jumping across tips of iceberg to make you understand, at least give you the idea, the foundational understanding of which direction you need to go. And then carry forward, you can ask your seniors, your teachers, and certainly you can ask me at any point of time if you have any questions later on. So what are we going to expect today? Well, obviously, we'll talk a little bit about the most common, subject, osteoarthritis, where most of your clients will, come with the problems. Then they will obviously have some amount of low back pain. So the research says that about 76 to 78% of the entire global population will have an episode of low back pain at some point in their lifetime. So that's huge, right? And that's where you come into play to make them understand the importance of exercise more than modalities. Modalities anyone can do, but exercises, nah, you can do the best, and we are the very best at it. So we'll talk about the principles and then the benefits and the functions and We'll end up with a Q&A session. Now, so when I talk, it's like I will tell you like a story. And if you certainly have any questions, write them in a chat box for Dr. Pradhan to ask me at the end of the session. Otherwise, just absorb the information that we are going to discuss today and let me know if you like it or not. So I always start with a token of pictures, multitude of pictures of what happens. And these are very key features that you will come across, like a pain in a specific location, right? On this girl over here, or someone who is an IT professional having low back pain issues, or someone who is a little bit older, geriatric, having probably, disc problems or any kind of, back problems, have difficulty sleeping, in sleeping, especially one who is very acute. Then this common area is extremely, technical and very easy for patients to delineate that, oh, I have pain around the hips and just across the above the iliac crest and those sort of stuff. And very, very important in US, in our association like APTA, there is a Vision 2020. Now that Vision 2020 is gone up to Vision 2025, where we are promoting women's health, where obviously women's health is particularly in pregnancy, not only just pregnancy or post-pregnancy, it's prenatal too. So there are lots and lots of exercises and ergonomic stuff that PT that you can provide to your patient in terms of guidelines that she will be extremely benefited during childbirth and for sure post childbirth. And this picture kind of says it all, that every day we are aging. At some point in our lifetime, we probably will hold a stick, and that individual who is basically holding his back is what the common theme of today's discussion and the world is going at: back pain. And that could be your neck pain to mid back pain to low back pain to pelvic or SI joint pain to innominate slips and stuff. But you essentially have everything is posterior or in the back. Got it? All right. So I always like to share some myths and facts of life. So what is the myth that you come across? Trying to exercise and get healthy is pointless because decline in old age is inevitable. Probably it is, but there are multiple animal models by one of our collaborator labs in University of Minnesota, where we have animal models like mice and rat, which shows when they are older, quote unquote, like comparatively saying 78 to 82 years old, not the mice, but in human age of 78 to 82 years old, even those mice who exercise aerobically, like, there are, according to American Heart Association, that you need to take 10,000 steps a day to keep yourself healthy. Yourself meaning cardiovascular, pulmonary wise healthy, right? So taking that into account, that concept into account, we actually, or not we, but one of our collaborator lab actually did that exercise for the mice, and it's pretty cool to see them running around and all. But on the serious note, it was shown after doing muscle biopsy that they have grown in terms of volume or the muscles, skeletal muscles have grown in terms of hypertrophy, and also again only found in animal models only. Hyperplasia, which basically means there is separation of muscle fibers, which in human it is probably not seen, and it is impossible at some point because you cannot do just biopsy for the sake of doing. There are lots of other medical legal issues in US at least that we cannot perform that. But as of now, it has been seen that even though decline of muscle bulk and muscle health through old age is inevitable, but you can bring it back to a certain extent if you do the exercises as recommended by you guys as physios. Exercise isn't safe for someone my age. I don't want to fall and break a hip. That's extremely a very common notion worldwide. I mean, I have been to multiple continents in and around the world, and this is a very common thing that students tell me about it. Okay, my grandma or grandparent doesn't want to because they think that they will break. That's obviously not true, because if you see why it's not true, two things. You need gravitational pull. That's the reason astronauts, even though they run in the International Space Station, they run countless numbers of hours on treadmill, but still they are osteoporotic, because you need gravitational pull to improve calcium bonding within the bone, inside the bone, right? The spongy bone, the diaphysis, metaphysis, and epiphysis, everything needs to be intact. The Haversian system, if you remember from anatomy first year. So these things tend to be intact. If you only exercise, if you don't, if you are bedridden, then there is no point. Your bones will actually start shrinking. In fact, I remember probably about 3 or 4 years back, NASA, your space agency in US, applied, gave out some research ideas. And obviously, whenever it comes to NASA giving out some research ideas, they share it with big labs. So I was part of a big lab, and they sent it to us saying that, okay, we'll give you, this much of, compensation, but 2 months you have to stay in your own bedroom. So they have a room, you have to stay in that room and do whatever you like, but 18 hours in a day you cannot get up from the bed. The study was at the end was recalled, because who will want to sleep or lay on, not just sleep, but lay on the bed for 18 hours a day, like for 2 months at a stretch, right? It is just impossible. It is not even logical or practical, because certainly there would be so much complications that goes on. And that is exactly where this comes on. Exercise and diet are key to keep you healthy or your clients healthy. All right. Exercise in this case can cause heart attack, and cardio is so good, it will certainly not. Exercise will lead to joint pain. If it's acute, then probably you need to tone down the exercises and maybe do some isometrics to start with, and slowly gather on pace when the inflammatory responses reduce, and then you start doing your isotonics and other strength training. But certainly you have to address the exercise part of your regimen or prescription. So what is the reality? Exercise builds strength, balance, and research indicates that inactivity can lead to seniors to lose their independence. I'll tell you another research thing. In US, people like who are more than 67 or 68 tend to live in a community called senior living, similar to what we have in Kolkata, which is completely a replica of what we have done in US, or what is the norm in US. Is in Newtown there is something with whatever, I forgot that name. So essentially what happens is the rate of mortality is more in aging individuals after a fall. So if someone loses their balance, coordination, or trips and then gets bedridden, it is higher likelihood for them to pass away with chest complications or any other complications, but you have to make your client remain as independent as possible to prevent this kind of situation from arising, right? And studies show that exercising helps with arthritic pain, and you know that by now that arthritis is an inflammatory response. There is an ebb and flow, meaning there is a wave. When the wave is too much, that's an inflammatory response is too much, maybe you can cut down on the exercises a little bit, but when that flow goes away, then you give an exercises, and the more you help that your client exercise, the less that wave will be, and the frequency will be much lesser and lesser. I really like this photo of this German individual, this grandma probably, who is like boxing, and boxing is like a craze in Western Europe and also some in Canada too, because it has shown that low impact exercises have with axial loading, you increase calcium deposition in the long bones. So boxing, if you might, in a low resistance band or TheraBand, like doing this is much important or good for skeletal growth and development. Just a tidbit for you. Okay, again, you have known OA is so common globally. So radiographic evidence of osteoarthritis is present in the majority of people over the age of 65, 80% of those over 75. What does that mean? That if you give your patient some preventative prehab exercises for the knee, for the low back, for the neck, maybe this recurrence or occurrence of osteoarthritis, maybe you can push it back to a later stage, maybe 67, maybe 70 years. So that way they can live a more better independent life. So that's what I am getting at. Level of independence, quality of living should be your aim, should be your patient's aim, how you can achieve and improve on that. Okay. So again, take home story for this slide is, if someone who is 65 years probably will suffer from OA, then why don't you not give them prehab exercises of the knee, hip and ankle or whatnot when he was 45 or even when he was 40, right? 3 or 4 days a week he can do that exercise prescription as recommended by you. So certainly you can increase that age of when the osteoarthritis can set in, right? So that's a great idea for you, that how I can clinically change the concept of research in my clinical practice. And this is what evidence-based practice means. Evidence-based practice doesn't mean whatever it says in the research I'll blindly follow, because there are different levels of research also, correct? All right, commonly cited reason for not wanting to pursue an exercise program, because amar haatute batha, mera ghutna mein dard hai, so that's why I don't want to do. If someone who is really old and is going for a knee replacement, the post-op recovery takes way more time, because obviously the joint is frail, the muscles are atrophied. How can just a surgeon putting in an implant just magically make him or her walk? It is nearly impossible. It is your duty to make that individual walk again. So prehab that individual who is going under the knife, right? 2 weeks or 3 weeks prior to that, go to their patients and give them the exercises, so that when they go under surgery, they are already stronger in terms of their relative strength of the muscles and the bones. Low back pain, 4 out of 5 individuals has major episodes. As I said earlier, right? 50% of working age people admit to low back pain. I mean, I have multitude of patients coming from, IT professionals, or even coming from outside the state, coming over here and staying and getting treated because they are not finding relief. Okay, we can apply modalities. Then what? Modalities is like medication. Modalities stop, after some time, pain is back again. So how can you linger that or postpone that recurrence? How can you reduce the chances of that recurrence? Is through exercise prescription. So if you have to know anatomy and biomechanics as like the back of your hand to know how to give and prescribe exercise regimen. Back pain is a common reason exercise programs are stopped. আমার ব্যথা বেড়ে যাচ্ছে, मेरा कमर का दर्द बढ़ गया इसलिए मैं कर नहीं पा रहा हूं. So obviously that is not incorrect, but then the exercise that you probably give needs to be modified, needs to be structured, needs to go at a lower level and then ramp it up, right? So this probably is a good segue for me to tell you about principles of exercise prescription. Now, probably you know, or you may not have heard from somewhere else, that exercise is based on frequency, intensity, duration, and mode. I like this, but I don't, completely follow this rule. According to ACSM, that is American College of Sports Medicine, basically ACSM provides exercise prescriptions and guidelines to all elite athletes in US and the world over. Like, if you go in for Rohit Shetty, who just got out from an injury, he was also following ACSM guidelines. You have to follow ACSM guidelines because they are so evidence-based and based on certain other biomechanical principles. So then how is FIDM important for you? Well, frequency is based on the acuteness or the chronicity of the condition of that individual. You have to change the frequency. My go-to prescription is 10 counts, 10 repetitions, 2 sets a day. But I don't judge that threshold based on that individual's problem. I see how the muscle is reacting to a stretch reflex. I see how the muscle is reacting to a strength reflex, which essentially means like a grade 5, you try to move that individual isometrically. If the patient is not able to move it, okay, that's grade 5. So, that's called muscle reflex. Okay. So those are the two criteria kind of thing, which helps me gain my exercise prescription regimen. How much frequency I will give, is the intensity 90% of max or 50% of max or even 30% of max. In fact, right now I have a national silver medalist gymnast. He had a fall and tore his rotator cuff and anterior part of the labrum. So then what I basically did is gave him certain exercises. Then he came back and said, oh, I was not able to do, I felt so much pain, which is obvious. I did not realize that just because I did not, since he's a national level silver medalist, the muscle bulk in here is humongous, and he's more of a rings type of ring gymnast, right? If you understand that. So now that muscle bulk, I did not see the amount of inflammatory response that is underneath, right? So that's the thing. When I gave that threshold and he said that's pain, that was a cue for me to reduce the frequency, intensity, duration. Mode, I don't usually change. So what is mode? Mode means, will I give concentric, eccentric? Will I do, isometric, isotonic? So those are the variables that mode pertains to. For me, since a patient comes to me with acute conditions, I generally go in with very different sort of exercise prescription that I doubt you probably have heard, but I'm not sure how much of you know. It's based off of motor control, like neurokinetic therapy for David Weinstock. So David, I have taken those courses in LA, Los Angeles. So there are motor control prescriptions used through frontal cortex, which kind of retrains or re-governs certain exercise regimen based on the neuromuscular modulation. So that's on a completely different off topic. We are talking, it is though exercise, but on a different level of exercise. But mode is basically if it's isotonic, isometric, this and that. But if someone who is acute, I usually prescribe them isometric exercises, which you all know, close kinetic chain exercises to reduce chances of any kind of, trauma and all, right? And then I'll ramp it up slowly and surely. So that's the mode part. Frequency, intensity, duration is variable, and that should be variable for each patient, and that should be variable for each phase the patient is in. If the patient is with you for 3 weeks time, then each week that patient should have developed and the phase will change. So ACSM, American College of Sports Medicine, have guidelines, and I'm not sure if you can take those courses staying in India, but they have courses, and if you go through them, then you basically know and understand what are those levels and the prime 6 and level 6 and level 7 are for elite athletes basically. Okay, man, this is one of my favorite, which I like dead believe in. From in my 19 years of clinical experience, I kind of follow this kind of a algorithm. I am calling it algorithm. I doubt you will find anywhere in the book in algorithm, but if you look through my research, I address it as an algorithmic values. So I usually, if the patient does not have any fracture or instability, there is no unstable joint or bone mechanics, I start with mobility, because then obviously that patient has come with some kind of restriction. To improve restriction, I need mobility. Then I go in with stability. I like to do stability in multiple ways. I'll give you two examples of it. One is co-contraction. What do I mean by co-contraction? Knee arthritis patients. So knee arthritis patient who is not able to bend the knee, however much angle that individual is bending, I tell them to squat at that level and ask them to sit there for 30 seconds to maybe 40 seconds, depending on the other factors. So what am I trying to do? I am trying to co-contract the quadriceps and hamstrings. I change the foot angulations a little bit to help the VMO fire better, so that the patella is again turning medially. So when the patella is turning medially and the VMO is firing, the knee mechanics is tending to be as normal as possible for that individual, right? So that's how I create stability program. That's one aspect. Then I give longitudinal pressure to improve proprioception and kinesthetic motions, right? The mechanoreceptors. So anything that is longitudinal through and through long bones, I apply pressure, or I apply close kinetic, tell them to do close kinetic chains, which goes in through the longitudinal angle of the bone or through the bone, that helps to improve mechanoceptors, proprioceptors, and the like Pacinian corpuscles, if you remember, pressure sensors, Pacinian corpuscles. So I use those kind of techniques to improve stability. And then controlled mobility is, I am very good at. I am actually. Controlled mobility is where I do motor control exercises, and my motor control exercises are completely off the book. There are workshops that you have to do to understand what controlled mobility means. It is based on the principles of DNS, dynamic neuromuscular systems, and also NKT or neurokinetic techniques or therapy. So that's where the neuromotor control comes into play. And function, we all know function is basically activities of daily living. The goal of that patient, my patient when comes, I cannot comb my hair. Well, that's a function that I want my patient to achieve. I cannot scratch my back. Then वो मेरा patient के लिए function है जो उसको करना पड़ेगा at the end of the treatment session. ठीक है? All right. Now let's jump into benefits. I'm not going to go through all the benefits because it's easy peasy to understand. But what I would like to do is, or state is, balance, improve posture. Since I'm an osteopath, at the end of the day, I always see the body as a whole. Meaning, if someone has a pain in the shoulder, I tell them to walk. And I see if there are any nuances that catches my eye. And if there are, I will actually, other than also taking care of, I don't believe in pain. Pain is very subjective. So I don't reduce pain. I reduce the cause, or try to reduce the cause. I cannot cure. Cure is a misnomer to me, because we are already degenerating from the day we are born. So there is nothing called cure in my language. So what I'm trying to do is reduce what the pain, what the patient's problem is, and pain is probably one of the factors that I have to reduce, other than motion restriction, stiffness, strain, whatever, whatnot the patient is complaining about. So for me, it is essential, critical to maintain posture, a correct posture, not a straight posture. Straight posture again is an incorrect way of thinking. There is nothing called straight posture, but that individual's correct posture. And for me, what my posture is will be different for you, will be different from your better half, will be different for your parents also. Everyone has the center of gravity rotates in certain axis system. Again, I don't want to go into surgical biomechanics and stuff, but that's where it will lead to essentially. So coming back to full closure is posture is key. And if your posture is correct, then your balance will also be inherently better. I'm not saying correct, but better. Then I try to improve balance and coordination also. That helps me to improve muscle strength, flexibility, density of bones, and obviously improves their stress, reduces stress levels and improve the mood of that individual. Also, I do one thing that I have learned after reading Freud, that German psychologist Freud, if you remember. Freud has 3 volumes of books, and if you get a chance, and please go through it, you will have a different dimension of seeing an individual prior to and post reading his books and articles. So I like to talk in certain tone and pitch, and use certain words to help their frontal cortex trigger certain brain waves. So you have to read through those things, and then there are certain very minimal researches which has been already done in Eastern Europe, which actually shows, in Austria actually, which has shown to improve those kind of things when you say, verbalize, mimic, do the exercises in front and let them do it, like mirroring. Okay, so those are very basic neuromotor concept. Those who are in neurology, they very well know it. I honestly don't know that much. So I try to use that kind of concept to help improve my patient's ability to remember, retain, and maintain. Remember, retain, maintain the exercises. If I'm able to do that in the frontal cortex, after about 4 months, maybe sometimes 8 months, that remembrance goes out down to the subconscious level. Again, Freud's theory. So that then when it goes in that subconscious level, then I leave the patient and I know that the patient will be good for a long period of time. That particular problem should not recur. Should not. I cannot 100%. No one can 100% guarantee, right? So should not recur. If that the pattern, the neurological thinking goes in the subconscious level, that it stays right there for most of the time, lifetime. That's about it for this one. So for me, as key is to improve balance and improve posture. That is my go-to. All right, in terms of function, so it can be the flexibility, strength, control, overall fitness. You all know this, but I don't go in with strength. I don't go in with overall fitness, because overall fitness will always be at the end. I don't go with strength on the very first time. The first thing that I like to do is control. If I have seen, like in my clients, I have seen here or abroad, I have seen most of them, especially those who are adults, they have the strength. If they walk to your clinic, they should have the strength, right? But they may not have the control. The correct pattern of motion is what I am talking about, what control means. The correct pattern. If I am having drinking water like this, that's a correct pattern. I don't want to drink water like this. I probably can drink, but is this correct? No, it's not. So there is some kind of gibberish thing that goes on in the frontal cortex that is preventing them to do motor control. The motor control center, MCC, is in cerebellum though. Okay, but that's basically it. The center is in cerebellum, but then it comes in front. Here it's where the pattern forms. Okay, the correct pattern. So if the pattern is incorrect, then I give control, and most of them the pattern is incorrect because there is some postural correction that needs to be done. So I improve core steadiness, neuromuscular control, and then try to implement these kind of exercises at the subconscious level. Don't think this subconscious level function can come overnight. Not even in months. In some cases, it takes 4 months. In most cases, it probably takes more than 6 months, maybe 8 months also, or more. Who knows? And it also depends on the client and depends on you, how you are doing it also. So control is primary for me, and then I also apply flexibility. In terms of flexibility, if someone comes to my clinic, I usually do MFRs. I like to do MFRs, myofascial releases, and there are varieties of MFRs under the scope of the healthcare practice. I do what Dr. Greenman taught us long back, like in 2009, 2011. That's when he was like at his peak. Dr. Philip Greenman, he's the modern god of osteopathy, basically. So he told us certain things to do with MFR, and that's what I do in terms of improving flexibility. All right, now again, you know these exercises that are overall fitness. I'll go back one slide to check. This is the overall fitness. I mean, exercise that gets you moving, increases heart rate, improve the health of the heart, lungs, and blah, 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 improves endurance, weight loss, and all of this, right? And you can do aerobic, cardio, this and that. But there are certain specific things that I have on this slide. Swimming or water exercises classes. What classes meaning? Group. If one individual is doing by himself or herself, the outcome is not that impactful as 5 or 6 individuals doing the exact same thing. There is a sense of camaraderie. There is a sense of camaraderie that delves or develops within this group that helps them make more stronger bond and help improve, like a good healthy competition. Like if she's doing it, why can't I do it also? That kind of a thing. Tai Chi, probably have heard, this is more of a Korean kind of martial art, or a Southern Chinese kind of martial art. Very slow motion movement. This is I have done that like for the sake of doing it, to understand the concept of philosophy of it. It is very slow. And honestly, I did not like it, but I know who are on the older side of the age spectrum, they probably will be way benefited, because it's a slow, very fluid, very subtle motion, which improves your balance, coordination. And the Korean, South Koreans, and the Southern Chinese say yin and yang, the positive and the negative. That kind of balances the energy within you. That's what their concept is. Group walking, I love to help my clients do group therapy, group exercise. What was I saying? Yes. So let's say if even in the Corona situation, you cannot go out, but certainly you can do it if there are 2 or 3 in the family who is welcomed about those kind of things. So my exercise prescription is such that that individual can do, his children can do, or his or her parents can also do. Everyone in the family should be able to do it. And if they do it even once a week or twice a week, that is proves a huge impact in their mindset, a huge boost in motivation in their mindset. Try it out and you can, see the result for yourself. Low impact aerobics is like boxing. Remember, I told you anything that is axial loading, slight impact axial loading helps to improve bone deposition or calcium deposition within the bone, and also cartilage health. And strength training, obviously, high intensity training, HIT, there was CrossFit and all. There are different types of strength training depending on the individual. Okay, right. Now, training guidelines. There could be cardiorespiratory training, and there could be muscular strength and endurance. I don't do much of cardiorespiratory training because my clientele is not much of cardiopulmonary deficient. They are completely more of orthopedic or musculoskeletal ailment individual. So every adult should perform activities to maintain increased muscular strength and endurance. How many days? In at least 2 days. So please remember, at least a minimum of 2 days a week, you have to remember this, write it down so that you never forget. Write it, a note on your table or in your backpack or whatever. At least a minimum of 2 days a week, your client who has any kind of musculoskeletal or orthopedic issues should be doing strength training. That is extremely beneficial for the bones, muscles, and soft tissue structures. Perform at least one set of 8 to 10 exercises that use all the major muscle group. I don't want you to be like this guy over here, or your clients, they probably don't need to be, but at least one set, which is probably 10 repetitions. It could be 5 repetitions also, based on how your client or your patient is able to handle the exercises, right? Depending on how your patient is able to do that. So just one set, and how many? 8 to 10 exercises, not for just one muscle or one joint, for all the. So the thing that we do at in US, in either in Mayo Clinic or in University of Minnesota, where I was located, at the end of the treatment session, it could be 2 weeks or it could be 3 weeks, we give them a chart, and probably I know some of you also do that in your clinic. You give example set of exercises, and that's a great thing. That's a great thing. But please be aware that they should be doing some amount of strength training, and that strength training could be any weights, right? It could be like a 2 kilo weight or a 3 kilo weight, depending on the comfort level of your clients. You give that weight, right? And that will be easy for you to do it. So don't forget, I'm not going in much into cardiorespiratory. Probably you know it. If you don't, it's like moderate intensity, that is brisk walking for more than 30 minutes. Now, remember what I said initially. AHA recommends 10,000 steps per day. So that probably takes on an average of 40 to 45 minutes. So that is basically your cardiorespiratory training. You don't have to do anything other than, take 10,000 steps a day for your patients. And then now though people have those, fit watches, or with smartphone, you have Google Fit or something, Samsung or S Health or something like that. That will count the number of steps. Then you can do. Someone probably has their mic turned on. Could you please turn it off and double check if your mic is turned off? There is an echo over here. Thank you. All right, so that's what we talked about: strength, endurance, and cardiovascular. Okay, strategies, and this is one of my favorite exercises, actually. What I have shown over here, lifetime program. So what is important for you to note is that, all right, my gosh, could anyone stop that mic noise? I'm not sure how to do that. AP technical team, any idea if you can do that from your end and mute?
Done, sir, done.
All right, thank you so much, appreciate it. So the strategies, develop a lifetime program. So I don't think that when a patient comes to me, he or she will come to me and after another year or so with the same problem. If that happens, then I am a failure. I am a failure. Then I did not do justice for my patient. I have to see to that patient to the best of my ability that he or she should not come back within a year, maybe 2 years, maybe 3 years or 5 years, depending on age and other variables, obviously, with the same problem. Then what should I need to do to maintain that lifetime program? I tell my patients to do these exercises, and after 3 or 4 months, come back to me for a day, and I will give you another set of exercises. So that helps them grow up level by level. And then the patient knows this is what my physio has told me to do it. And so the regimen is intact. You know that your patient is following, and the patient likes it, because there is a change in cuisine. Every day you cannot have march and bhat and like it, right? Some days you would like a chicken biryani too. So it goes like the same exercise over and over again. Who would like it, right? So change and mix and match the exercises at some time. That will help keep the motivation, and remain and do the exercises with the same passion and motivation. Flexibility, strengthening, blah 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 is all cross training. I do like CrossFit. In India, I'm not able to work out, and with Corona, obviously I cannot. But whenever I'm in US, every single day I work out, and my workout is not going to the gym and build muscles. No, I like to play. Either I play beach volleyball, or I swim, or I go for skiing, or anything that is aerobic and has cross functionality. I'm not saying every Saturday I know I play tennis. I'm not playing tennis Monday to Sunday. That doesn't help the body, or the brain will go in a plateau phase. You have to shock the muscles to make those changes. So every single day I play or do something different in terms of activities to understand and make my muscles not know what's going to happen next. So that is what cross training is all about. You have to change, similar to circuit training, but a little bit different one. in terms of the protocols are different based on circuit training and cross training. It is essential for optimizing musculoskeletal health. Well, obviously, that is the reason I am talking today, preventing chronic diseases and minimizing chronic injuries and pain. All right, core stability. Now, last, I think I have taken probably more than now 20 webinars already over the 6 or 9 months, probably during lockdown. Most of the time, the common question that I get is, okay, when I do core stability, I will do that bottom exercise, plank. Nah, never. According to Dr. Shirley Sharman's, and probably you have heard her name through Sharman's exercise of low back, right? She's huge in low back core exercise and developing abdominal bracing systems and all. So we know each other because our lab collaborates with her lab. So both our labs are together in building evidence-based exercise prescriptions and protocols. So the first thing for core stability is not the plank exercise right over this picture that I have, have it, but breathing. Most of the time, my clients have incorrect, improper, infunctional or unfunctional breathing patterns. There are different types of breathing patterns. I have a certain set of breathing pattern, and you can either follow that to the best of your ability, or read through different research articles and see which breathing patterns you like the most and accordingly do it. I like Shirley Sharman's bracing system, level 1 to level 6, and it is not just breathing, but it improves breathing system. Now, what do I mean by breathing system, which is actually the basis of core stability? You have to think from here till my waist, from here till here, the entire trunk is like a cylinder, The top is here, middle is here, bottom is obviously at the level of the pelvis. So I'm kind of thinking how much I should say. So what your mindset, or what you need to tell your patient is hook lying or crook lying. The breathing will be such that there is no expansion of the lungs or the thoracic cage or the rib cage, no expansion of the rib cage. The feeling of breathing is that you have to engulf as much air as possible and push it down into the abdomen, and if possible to the lower abdomen, where basically lower abdomen, the base, the bottom part of the pelvis. That's where the thought process is. I am thinking that while breathing in, that my diaphragm is going down, and the air is going down into the abdomen and into the lower abdomen. And there are again protocols. Don't just listen to what I just said and blurt it out with your patient. Go over the research articles and you will get a hang of it. So that is the first level of core stability. And I do multiple other multi-feeders and other retraining and stuff, and semispinalis and spinalis retraining. I do, TA, transversus abdominis retraining and all. And then I go in for planks. Planks are like level 2 for me. I start with level 0, level 1, level 2 is basically plank. And then there are different versions of planks. This is a higher level version of plank that I have in here. So that's basically the fundamental principle of core stability. I know in YouTube, when you write core stability, they'll show you plank, but that's not incorrect. But that's for one who is already, this is normal, already who is normal. Patients come subnormal. They will not be able to do that, right? So to bring them to normal and do that, I am okay with that. But to start plank when someone is subnormal, that's a completely no. You will not get much of a result, not like any result whatsoever. Provide several benefits that we have talked about. Pilates is an alternative approach. Yes, it is, but that's on the higher end. Pilates, cross training and all are on the, because they are very bouncy. Pilates is bouncy by nature. So bouncy meaning probably control after control mobility. Remember on those 4 principles that I follow, the algorithm that I follow: mobility, stability, controlled mobility, function. Pilates comes with between that control, mobility, and function phase, basically. Holistic health, right? So this is basically, you can do yoga programs and Tai Chi to improve stability. My pet peeve is I don't like to give strength training to my patients. It is of no use to them. When initially, I'm talking, not talking long term, initially, I always give motor control exercises and flexibility exercises. Then after they achieve those two layers, then I give them strength training to improve the back muscles. The problem, okay, now you can ask me why, or there is always a question of why, but you have to think through why actually at some point of time. So the thing is, when you are doing strength training, let's say for low back pain, you are doing for iliocostalis, longissimus, and spinalis muscle. Those are the three main erector spinae that you have from the thoracic cage to the lumbar spine, end of lumbar spine to sacrum, S2, S3. And you do have QL, but I'm negating out the QL because their fiber orientations are different, their angulations are different, their line of pull is also different. So the exercise is also different. So in terms of erector spinae, if you are, someone has low back pain and I did not give them neuromotor control and I gave them some kind of asanas bhujanga asana ki sab bole asan pasan diye dilam, and then think, oh, the pain is gone, then I am good. Probably the pain is gone, but that does not mean it will not correct in 6 months, 4 months, or even 8 months, right? The thing is, the control part of the spinal stability never comes from the bulk muscles, big muscles, long muscles, tall muscles. It always comes from small muscles, thin muscles, split of muscles, multi-level muscles like multifidus, semispinalis, and rotatores, the three most crucial, spinal stabilizers possible. So that's the rationale. Do not give bulk, big muscle strength, then they overpower those small muscles and there will not be any stability, but just the strength. That will not help in a long run at all. Okay, so that's the reason for me to give more stability, and that stability is either you can do Tai Chi. That's a picture showing this Tai Chi mechanism. See how beautiful balance and coordination that one can do. I give some Tai Chi principles based exercises, but on someone who has a little bit of a level 2 balance, I give Tai Chi exercises to them. And then yoga, so I don't have to say anything. You all know how good yoga is. Sometimes I certainly do art of breathing, which essentially means pranayam in US. So art of breathing is the principle I give to help improve the oxygenation and so that there is a reduction in carbonic acid, HCO3 minus, right? Too much of carbon dioxide. That helps to do, to eliminate carbonic acid from the blood as carbon dioxide. Okay, so now jumping from exercise to nutrition. So how is exercise and nutrition is related? Oh, they are very much related. If you don't have proper nutrition, your client will not be able to do exercises, have the endurance, have the motivation, have the power, have the strength, and have all the other factors and variables, because nutrition gives them the impetus, the nutritional values of ions and the vitamins and the supplements that help them motivate to do exercises. So these are basically taken from FDA, and now probably FDA after Pfizer and Moderna vaccination. FDA is our Food and Drug Administration in US. So these are basically FDA's health chart or health nutrition type of thing. So consume fresh colored fruits and vegetables 4 to 5 each day, and most of us follow to the T, and I do follow every day basically whatever FDA suggests. Eat cold water fish. One of my favorites is basically halibut. I doubt you'll find it here. Anyway, so cold water fish, and then you take anti-inflammatory foods, and then minimize the intake of this and that, and avoid tobacco products. And you all know that. Now, this is probably good for your patients. I always give them information about a little bit of diet and nutrition. A very, very brief overview of diet and nutrition you should all know to help your client go through that process to change, or not change, but modify their routine, their diet to have on a better way. So seeds, sesame seed, flax seed, pumpkin. Now you can easily find all of these through Big Basket and Grofers or Spencer's. I know you can easily find that. Oats is fantastic because it has multiple, advantages which can be brought about by having oats daily. Brown rice and other cold water fish. Oh, also have as many, colored vegetables as possible, like alpha lipoic acid, right? If you heard about, orthosurgeons giving PRP injections in the knee joint or plasma rich protein anyway. So they have alpha lipoic acid also in there, which are very, very nascent, antioxidants which help in the development of matrix within the cartilage system. So that's fantastic to give a alpha lipoic acid, ALA. Dietary supplements, omega-3, selenium, everything coenzyme Q10. Coenzyme Q10, it's usually found in capsules as a dietary supplement. So if you want to, not prescribe, but, recommend to the patient, get an information from the pharmacy nearby if they sell coenzyme Q10. Otherwise, search for Amazon and Flipkart and ask them to have coenzyme Q10 because it has anti-inflammatory properties. Okay, because it's like an antioxidant. All right, so take home message. So what did we talk about today? There are gamut of stuffs that is still left. We not even touched the tip of the iceberg. As I said, it's a 2-year course of exercise prescription, and after exercise prescription masters, most of the students go in for athletic trainers in US. So this is their bread and butter, and I just touched probably a freckle of ice on that. Principles, we talked about the principles. Remember, oops.
Just wait for some time. Sanjay says is joining.
Okay, participants, I think there was some internet glitches. It will be corrected now, and Sanjay Sarkar sir will join us soon. By the meantime, I'll ask all the attendees, if you have any question, please put it on the chat box so that we can ask that question at the end of the session, and we'll have an interactive session at that time. Please feel free to ask the questions, whatever you want to ask. Right. Thank you, Dr. Manoj Hemram, for your recognition. Yes, the program is going great, and as we know, Dr. Sanjay Sarkar is a very good speaker, and he has joined now. Okay.
Yeah,
Dr.
I am
Sarkar?
so sorry. I don't know how, just whatever happened, it's like crashed everything. I'm super sorry.
No,
Please,
nothing issue. Please continue.
yes, sorry about that, guys. Apologize for that. Okay. Now what happened?
I think you have shared the screen rather you. Yeah, right.
Are you able to see it, right?
Yeah, we can see it.
Perfect. Okay. I'm close at the end right now. So, okay. We talked about principles, benefits, functions, guidelines, strategies, and nutrition. Plus, overall, remember one thing: mobility, stability, control mobility, function. And then you can certainly change the principles of frequency, intensity, duration, and mode to change exercise prescriptions. The other thing that I did not talk about is there are at least 2, maybe 3 or 4 researches that are like mostly Scandinavian research that has said that don't give overload with exercise. the brain can only remember so much. So if you have a dozen exercises, not only the patient it's a deterrent for the patients to perform those exercises. 12 exercises, who has the time, right, to do all those 12? So do not give more than 8. People say in US we don't give more than 6 actually, but I usually tend to give between 6 and 8 exercises for each phases, and then make them basically change it depending on their development and growth based on what I'm looking at and what I'm checking. Other than that, that's basically it. So those are the 3 things that I remember. Do not give way more exercises than need be. Don't give 8 is the number that you should remember. Don't give more than 8 exercises at 1 each for each phase. And then based on your client's development, change it accordingly. Wait. These are the resources that I have taken it from. This is my contact information if you want to be in touch with me for anything that you can think about. And then I'm open for questions. Go ahead.
Hello.
Yes, Dr. Pradhan.
Yes. Thank you for this beautiful session. We have
Thank you.
came to know about much more thing which we usually miss during our exercise prescription. And as you have said, it is a 2 years course, which is like quite long, which cannot be done by 1 hour, right? Even in India also we do have this exercise prescription for our masters in first year, right? So
yes, that we do. Yeah, that I have taken.
They're learning in that way. And when we start reading that exercise prescription after doing our BPT, that blasts our head, like how we used to think and how we are supposed to think, that complete context will change. So thank you very much. That's a eye opener for many of them who are sharing this thing. So we will go for these questions. Okay. Aisha Rana said, coenzyme Q10 can be prescribed to every age group?
So PTs don't prescribe, even if it's a supplement, right? So you have to recommend. You can recommend. I am pretty certain you can find it in capsules. They come as coenzyme Q10 capsules only. In the US, that's what we find. They come in jars like, multivitamin capsules. They come as coenzyme Q10 capsules only. Please search over Amazon or Flipkart and probably or NetMed somewhere. You will be able to find it out somewhere.
Okay, now
again, read. No,
sir, could you please
you can recommend.
Hello.
Sanjay sir, could you please stop screen share?
There.
Yeah, right. Fine.
Thank you.
We have Dr. Kalpana Jutsi ma'am with us. She is attending this program. She has a question that what is the difference between osteopathic practice and physiotherapy practice? Though it is not related to our topic, but if you can put one line on that.
Let's say both are similar yet different. It's like a mother with 2 children. So the origin is the same, physical, but osteopathic does more with alignment, realignment of bones and muscles, and in certain cases superficial nerves also, and fascia, obviously, I mean soft tissues. But in physical therapy, we take it a little bit on a different take. We do modalities approach, and we do exercises. We don't generally change the structural integrity. We don't generally change the structural integrity of the problem. But in osteopathy and through chiropractic techniques, you can change structural integrity of the pathological, or wherever there is a problem, you can certainly do that. So just a nutshell.
Thank you, Dr. Sarkar. Now we have a question from our Secretary of West Bengal branch, that is in mid-effort mode, intensity, duration, frequency, rate of progression, right? So can you please put a light on that?
So as I said earlier during my talk, frequency, intensity, duration, and mode will vary depending on the case of that individual. If it's acute, then you have to do subminimal. So how would you define subminimal? Subminimal, it is subjective. There is no definition of subminimal. Subminimal is specific for that individual. If someone has 7 out of 10 pain, then I'm not going to give more than 50% pressure or force in terms of all those exercises. Even if that's painful, then I will reduce that based on experience of that pathology, what you have, and that individual, what he or she is telling you. You have to change the frequency, intensity, duration according to the comfort level of that patient. You do not want to create extra pain, extra spasm, extra blah 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 negative stuff that is detrimental, and then the patient doesn't come back to you. That you will lose business. At the end, we are all business, right? So if you want to be in business, you have to understand and strategize the patient's exercise prescription based on what you deem is necessary, fit, and comfortable for that patient.
Right. Thank you, Dr. Sarkar. And we also have, I think, two more questions. That is Dr. Niharika Vide. She asked that, is there any other regime than Delorme's for intensity of fit principle?
I don't know. And why I'm saying bluntly, I don't know, because I don't even follow that. There are a little bit better approach to exercise prescription than Delorme and Watkins. I'm not saying it's bad, but there are better ones which uses a little bit of equipments to do it. But if you, let's say, don't have equipment, even if you are doing your 10 RM max, then it's also okay. But 10 RM max is the starting point for that individual to start the exercise regimen. If you think the patient is still not able to do, then reduce the weight, reduce the reps, reduce the counts, reduce the type of exercise, modify the type of exercise. There is a whole gamut of things that you can do. Don't base your exercise prescription on just one principle. It is not a good aspect of your knowledge. Exercise is multifaceted. It has multiple variables that has interplay in that shoulder pathology. Okay, I mean, some of your team here, individuals, know I have probably a 288 page write up on Google Scholar that deals with subacromial space only. And I talked about how it changes based on CT scan and other electromagnetic things, how the three-dimensional XYZ axis changes depending on even this rotation and this rotation, right? Internal and external rotation with the arm by the side, and internal and external rotation with the arm at 90 degree abducted, and internal and external rotation in scapular plane of abduction, which is approximately 38 degrees anterior to the coronal plane. In all the three planes, the EMG studies show that the muscles are variable. What will you do? Right? So you have to see where the problem lies. Is the problem over here, here, or here? Depending on that, you choose the principle that is deemed fit and necessary for that individual.
Okay, thank you. And I think there is no more question from this Zoom meeting, but we do have a question from our live FB, live Facebook. That is from, I think that is Guarluju Chung. Okay, I don't know whether I have pronounced right or wrong. He asked that, can you please elaborate the breathing pattern to assess LBP?
You have to attend the workshop to do that. So no, besides that, the breathing pattern is usually hook lying or crook lying, the very basic breathing pattern that I am saying. And then let's say you have to ask your patient that the entire trunk from the root of the neck to the base of the pelvis is like a cylinder. And when he or she breathes normally, then the breathing flow, and I have to this is visual imagery. I have to feel that the air is blowing and going past through the abdomen, through the lower abdomen. So that's a pattern. It takes a little bit time. These principles is followed in 2 or 3 different concepts. So and you have to go over the books or the workshops to actually understand. And it's not that simple. There are activation patterns with the fingers that you have to tap. There are areas what you have to do to understand the mechanism. It's not that simple, because you have to phrenic nerves, which goes through the diaphragm. So you can actually tap in the phrenic nerve. There are certain rules for that and cues to do it to improve diaphragm flow also. So that's very, very deep we are going right now. So just overall, just tell them to breathe as far down as possible towards the belly button and actually crossing the belly button. All right, go ahead, Dr. Pratap.
Right. Okay, I think that's all for the questions.
Okay.
We will now like to ask Dr. Kaushik Mullik, Vice President of West Bengal Branch IIP, to give a note of thanks.
Thank you. Thank you, Anista. Sanjay sir always in rocking mode. Sir webinar is like it's totally different. I think we can do workshop from Sanjay sir and do webinar more than 100 or something. Sanjay sir is always wonderful. Thank you, sir. And this is the first webinar from Midnapur district branch. I welcome to Midnapur district branch. They will definitely do some more workshop or do more webinar. Thank you. Thanks a lot.
Okay. Thank you, Dr. Kaushik Mullik. And I would like to ask the Secretary of West Bengal IIP branch, Dr. Arindam Sheth, to speak a note. Dr. Arindam Sheth. Dr. Sheth, you are not visible.
Arindam, start video.
Network evening, although it is not like 10:30. Yeah. We already start the video. Hello.
No, we are not able to see you yet.
It is audible or?
Yes, you are audible.
Okay, no issues. If there is a network issues, you can speak. It's okay if you don't open the video. I think there is some network issue with Dr. Sheth.
Arindam, you could stop the video and just have the bandwidth for the audio. Maybe you can try that. Stop that.
Yes, that will help you more. You just keep the audio on. We are not able to hear also anything. And your video is freezed now.
You can rejoin. Dr. Pradhan, maybe you can ask someone else while
yes, that's fine. Okay, Dr. Sheth, you please rejoin again. You just log off and then rejoin. Fine. Then we will ask Dr. Nimai Chandra Das, who is the convener of IIP Paschim Medinipur. As this is the first webinar of IIP Paschim Medinipur branch, so I would like to invite Dr. Nimai Chandra Das to give a thanks note. Hello, Dr. Nimaida. Dr. Nimai Chandra Das. Hello, can you hear us?
Sir, please unmute. Sir, I am sending a request. Please unmute. Ask to start video.
Please open your video and unmute yourself.
video could be a problem for him where he lives. So audio maybe.
Yeah, at least an audio.
Hello.
Yes, sir. Sir.
শোনা যাচ্ছে বলুন.
Many thanks to Dr. Sanjay Sarkar. He is agreed to speak in the webinar. Many thanks. Hello. Many
Yes, you're
thanks.
audible.
Yes,
You're
sir.
audible.
Yes, sir. Sir, bolun, sir, bolun.
Many thanks. Many thanks to Sanjay Sarkar, as my brother. He's agreed to speak in the webinar. Many thanks. I congratulate to Dr. Sanjay Sarkar.
Thank you. Thank you,
you.
Dr. Dash.
Thank you, Dr. Dash. So I think, Dr. Sarkar, we will conclude the program today. Dr. Seth, has he joined yet?
No,
No, right.
again logged off.
Okay, fine. I think there is a network issue, so not a problem. We have a beautiful session of exercise prescription, though it's a basics, as you have said, but
Very.
it has a lot of information which will help our physiotherapists to think in a
Hopefully.
different context.
Hopefully.
Especially the
Yeah.
as you have said, it's kind of a holistic. Though we need to think about from the subnormal state. The patient is not a normal person. The patient is always a subnormal state, and we have to train them from the subnormal state and make them normal at least.
Yes.
And if they want to do expertise level, there are also options for that. And
Right.
I like one more thing what you have spoke very nicely, that is about the breathing. So we, in exercise prescription, we usually forget about that breathing. We give exercises, we'll ask them to do that, do this, but we sometimes do not ask them to how to breathe while doing the exercise, because it plays a major role, especially when we're talking about a core. The core will
Right.
be helped by the breathing during the exercises what is being prescribed.
Very right.
So,
Yeah.
for me, it is the take-home message that always keep that in
Oh,
mind.
thank you.
When you are prescribing an exercise, use the breathing exercise for that. And obviously,
Yes.
we'll like to thank from IIP Paschim Medinipur branch and IIP West Bengal branch for your time and your beautiful knowledge sharing. And this experience is going to help many people in their prescriptions of exercises. And we have to remember that exercise is the prime thing for us, right? So
Exactly. Not modalities, exercise, not modalities.
Modalities can only remove the symptoms, but exercise is going to cure it actually. So we have
exactly
that context. So thank you, Dr. Sarkar, and I think we can conclude the program for today. And thank you all the attendees and panelists who have joined there and given your time here. Thank you very much. And this particular recording will be available at Facebook, and it was there in live. And obviously, you can see it later if you want. If you have not got the time to see today, okay, because it's late in the night, maybe, and also Saturday late night, right? So if you want to hear it later, you can hear it from the IAP page. Please subscribe the page, and you will find this particular beautiful session there, and then you can see and give your comments. If possible, we will give the answer later, and you can join it later. And if you subscribe, you will get an information regularly that which programs is going to come, right? So thank you very much for your session, and we'd like to end now today. Okay, good night to everyone.
All right, good night. Thank you
for such wonderful webinar, and thank you IAP Paschim Medinipur district branch for organizing such wonderful webinars. And now I request to everyone to please subscribe IAP India YouTube channel for getting regular notifications for all the webinars. You can also follow us on Instagram, LinkedIn, and Facebook. Thank you, and good night, everyone.
Thank you. Good night, everyone.
Good night.